we are simulating clinical situation where you have caries defect, or let's say a fresh composite filling, class 3 or class 4, between central and lateral incisor. And in such a cases, you have no interproximal contact on patient's tooth because the interproximal contact is already made by composite. Okay. So in these cases, if you have a pretty big fillings in proximal site, like a class 3, or you have your class 2, or you have your class 2, you don't have in a frontal teeth, right? You have class 4. You have class 3, class 4. Then you may have some trauma. Then you may have also some kind of open interproximal contacts all the way out. You just take the bore and you go all the way forward. So again, indications: big class 3, class 4 caries defects or composite fillings, tremas, diastemas, necessity to reorganize width of patient's teeth. For example, you close diastema between central incisors and you already have space between central incisors. But if you will close diastema just by central incisors, they will become very wide. So in such a case, you close diastema by central incisors, then you will have to prep central incisors from distal side, right? To let lateral incisors go more mesial. So in some cases, you will have to prep laterals from the distal side to let canines go there. So you're really reorganizing and playing with the width of patients' teeth by preparations for veneers in some clinical cases. So that will be indication for type 3. At type 3, by the way, one of the most common type of preparation that we have in our daily practice. What do we do in such a cases? We still keep our bore 14 between, but in this case, we are not going to use just the tip of the bore like we did for a simulation of type 2 prep. In this case, we keep it really vertical this way, okay? And you go all the way out. The thing that you have to be very careful is not to let your bore going to the lingual side. Otherwise, if you'll make anything from the lingual or palatal side, the pathway of insertion will be pretty compromised. Another thing that you have to be very careful is inclination of the bore. If you will do it this way or this way, one of the tooth will be prepped more than another. Okay, and you can get some problems, some undercuts, and so on. So keep your bore straight. Position your patient's head in order to see clear interproximal area, like I have here. Then I take my bore and I go all the way through. So we prep both central and lateral here together. So we shave it all the way out, almost like a crown, but for the crown we let our board to go to the lingual side. In our case, we go forward with the board. We continue moving it till you reach stomach, okay? Stomach of your patient is your destination. I'm kidding, but you have to really go forward. Otherwise, you may get some problems from interproximal. See? So we open it. We created now space for ceramic. And now it's step 1. It's not finished. Step 1 is rough and quick preparation. You just do initial geometry of prep and that's it. But since I work with a high speed medium grid bore, I can save some time moving these transitions from buccal to proximal, making these transitions more rounded. So I want to make these transitions a bit more rounded. And then after finishing that step, I will take, and you will take also, red bore. We will go for the higher magnification. We will do our finish lines, and we will do the final design of preparation. So step 1 is just a step to create initial geometry of your preps. So look what happens here now. You have your interproximal contacts open. There are no finish lines between. Just comparing to type 2. Look, when you have this type 2, you have also interproximal contact opened, but there are finish lines between, vertical finish lines. Here we don't have it because it makes no sense, for example, to make finish line in your composite. You just cross it, okay? But the transition here has to be rounded. And be careful with the gum, actually be careful with the gum because during step one, if you will be not accurate in this area and you decide to go really close to the gum, or even to do some finish lines, you may get a risk of the bleeding afterwards. So we just keep it a little bit supragingival. The rest of tiny preparations and designs will be done during step two with the red bore, which will be more precise and didactic and detailed. So let us summarize. Type 1 veneer prep is when you keep in the proximal contact of patient's teeth. It's almost for color change, a very minor shape change, getting volume of the teeth, but the contacts have to be intact. Okay, type 2, when you have, for example, black triangles, you have demineralized enamel, and you do minor shape change. Type 3, when you have caries defects, class 3, class 4, some traumas, heavy rotations, gaps, diastemas, necessity to reorganize width of patient's teeth. I will stop at this moment. I will let you do the same. Okay, so you will do also type 3, just open it and make everything rounded. Then we will have our lunch break, and after lunch break, we will start with the type step 2 preparation, which is very important, finish lines and everything. Okay, very good, my friends. Let's go. 14, still I use 14 medium grit because yeah, you can do it with a 16 also, but when you use 16, you may over prep. So it's better to start with a smaller one, and then probably you will increase width later on. Okay, so you ready? Come here. We're doing live on YouTube. Say hello to people. Hello, everybody from Prague and from Bucharest, right? And from Bucharest and from Kiev, don't forget.